earlier. So Lori and I have been meeting with potential collaborators for the intervention study, and people seem very focused on increasing provider competency around LGBT people. But we haven't seen that integrated with anti-racist approaches to providing care. And so my assumption is that people are more willing to acknowledge that they have challenges in providing best care to LGBTQ people because they'll figure there's things that they don't know. But I think people are less willing to admit that their practices are just inherently racist in the structures in which they are set up. Like the healthcare system is structured in a racist way, right? Because it has the way that it normally operates produces inequities. So to me, that's inherently racist. And so people are unwilling to admit that because they don't even want to teach accurate history in the schools, right? So as we're thinking about this potential intervention with healthcare providers, we're thinking about how can we, quote unquote, market this in a way that it's like how to take care of your whole patient. So they're not chopping people up into like, well, we can do this sexual minority piece, but we can't do this race piece, or we can do this gender piece, but we can't do this sexual orientation piece. But how do you take a whole person who might be experiencing multiple identities that are stigmatized or marginalized and provide the best quality care? And I haven't seen that.
I was going to say there, Dr. Treadway, the postdoctoral fellow that I mentioned, did do a poster. I was trying to pull it up. That it was looking for studies. It says LGBTQ patients in cancer care. It was looking at U.S. physician attitudes, biases, and interactions. So I believe she limited the search to physicians. I don't think it included kind of the other clinicians at the hospital or the hospital staff. And even then she found 18 studies. So not that many. And that, again, like Dr. Poteet said, that was just LGBTQ attitudes. It was not intersectional. It did not also include thinking about the intersection of racism and potential homophobia. Which actually goes right into Marianne's question, circles right back into Marianne's question, which is exactly where we'd like to take this next, right? We'd like to figure out, are there interventions that we can do? Not just with physicians, right? I mean, people are interacting with all types of folks when they walk into the door, and sometimes even before when they walk into the door. It's the staff, it's the people on the phone, it's the folks at the front desk, it's the people all the people that they see in the course of their care, the mammogram tech, right? All of the different folks who they're involved with. Can we develop an intervention that trains those folks on how to best meet the needs of Black sexual minority women, Black LGBTQ women, particularly with attention to those domains that we mentioned earlier, right? How do they increase autonomy and competence and relatedness? And how do we increase the trustworthiness of the system that people are operating in? I don't know that we know how we're going to do that yet. But that's what we're working on, trying to see what we can learn from our results to see what would need to happen in that sort of training and education program.